Hello, my name's Joel Dunning and I'm delighted to be here with Professor Enoch Akowuah. In this presidential week in the US, we're going to give you some light relief because actually here in the UK we have our own presidential elections for our national society, but unlike America we have just the most fabulous candidates and we are delighted that actually Enoch, we bullied you into trying to be our president, and so I thought we'd just like to get to know you a little bit more, all the amazing things you do, and I thought it'd be really interesting just to hear about some of your visions for the future in cardiothoracics, which are actually quite relevant worldwide. So just as a bit of background, I know you extremely well. You've been a consultant for 14 years. You've been absolutely fantastic, bit of a go-to person if I got any cardiac troubles. You've also led 5 missions to Ghana. You have a huge charitable arm to your experience. You're actually going out in just a couple of weeks' time, aren't you?
Indeed.
Absolutely. But probably the thing most people internationally would know you about it is your phenomenal research background. I'm going to tell it, you're literally the best professor in the UK. You did this amazing Maverick trial, mini mitral versus stenotomy, mini AVR versus stenotomy. Then you went to UK mini mitral, amazing data, proper randomized trials, and you've set up this beautiful unit that we stand in today, an amazing cardiovascular research. So maybe you could just start off a little bit about where you are today with your research background, and then what you hope to do in the future, things like best AVR that you presented at EACTS. So maybe tell us a bit about that.
Thank you very much, Joel, and thank you for inviting me onto the show. So yes, as you say, I'm an academic surgeon. Actually, I've been an academic surgeon for only about 5 or 6 years now, but it's been a really interesting journey. And I really, I got into academia really because I could see that it was really important for surgeons to start to shape the data and the evidence that underpins our practice. And so my special interest of practice is minimally invasive surgery, and as I started doing it, it was clear to me there was very little data to support what I do. Perhaps importantly, to explain to patients the benefits and risk of the treatments we're offering. And that's why I did those 2 trials in minimally invasive aortic and then minimally invasive mitral surgery. I do think clinical trials are really, really important, and I think there's some really crucial questions for us to answer as a specialty. In thoracic surgery, we're doing the RESTORE trial, another really important trial about really determining for the first time, and it is crazy to think that for the first time, having done this operation for so long, we're doing the first randomized control trial of patients who are having surgery versus patients who are not having active surgery to show its clinical and cost effectiveness. So I think that those are the challenges that we need to rise to as a specialty, and I think clinical trials providing that information both for us as practitioners, but also for our patients, is a critical part of that.
So at EACTS, you told them about the best AVR. I mean, I just think this is so important. Maybe just for a couple of minutes, tell us about this amazing...
Yeah, I have to say, best AVR is one of, I think, 4 or 5 trials that I'm selling as trials that we need to save the specialty. And it really is, because I think across coronary surgery, aortic valve surgery, mitral surgery, atrial fibrillation surgery, there are just some key questions that we need to answer as a specialty. So best AVR is really asking the question, the context is that there's been this dramatic change over the last 10 years where effectively we've stopped using mechanical aortic valves. So if you look at patients aged from 50 to 70 in the UK, we've now dropped the level of using mechanical valves in less than a quarter of such patients, which I think when I started my training was unthinkable. Putting a tissue valve in a 55-year-old person was just never done. But the practice has changed dramatically, and really in the context of TAVI. So surgeons essentially feel that they can treat the failing bioprosthesis with TAVI in every patient. The evidence to support that doesn't really exist. And importantly, we've never, since the trials that we did 30, 40 years ago, the big VA trials and the Edinburgh valve trials, we've never done another trial to compare mechanical and tissue valves. And so I think a trial in that age group, 50 to 70, looking at mechanical versus tissue valves and looking at survival is critically needed. And it's needed because all the retrospective data we have suggests that putting a tissue valve in confers a survival disadvantage for our patients. So we've got lots of data showing that we're doing potentially the wrong thing. Practice is changing in the direction of using more tissue valves, and unless we do a trial now, essentially over the next 5 years, by default, we're going to exclude mechanical valves from our practice completely, and we will never know whether, in fact, a mechanical valve with well-controlled anticoagulation was always the very, very best solution for long-term survival for that group of patients. So, I mean, that's an important question we need to answer. In the coronary field, similarly, we've now, I think, got to a place as a community where we understand the role of PCI in stable coronary artery disease, which is that PCI doesn't really confer survival advantage. We know that ischemia doesn't really matter. The REVIVE trial has showed us that. So we're kind of left with a question mark about what to do with patients with three-vessel disease who haven't got ischemia, who've got good ventricular function and very little in the way of symptoms. The American guidelines about 2 years ago downgraded coronary artery bypass graft surgery on the basis of the PCI trials. There was a huge outcry about that. But actually, we do now need to do the trial of CABG versus medical therapy in patients with three-vessel disease and find out whether in the contemporary era, CABG still confers survival advantage. I think that's a really important trial. And if we do it and it's positive, it again underpins our specialty. I could, as I say, there are 3 or 4 really important questions I think we need to answer. I think if we get the answers, those trials done, and the answers favour surgery, it really puts the specialty back where it was 10, 15 years ago.
Yeah, and that's absolutely. We literally could spend 2 hours.
We could just talk about trials.
But the key message: need to save the specialty through research, and obviously. Trying to take a leadership role on the SCTS is all about, where are we as a specialty in cardiothoracics worldwide, really. Indeed. So what do you think the key issues are for cardiothoracics worldwide? Well,
to be honest, I think maybe again a bit of context. 30, 40 years ago, the leaders of our specialty in the UK, people like Peter Goldstraw and John Walwick had a central challenge, which is to build units, train surgeons, design operations that were easy to teach, and really increase access to cardiothoracic services around the country. Okay, fast forward maybe another 20 years or so to sort of 10, 15 years ago, and the leaders at that time, Bruce Keogh, Simon Kendall, Graham Cooper, it was about reassuring patients, making sure the quality of practice was good, making sure there was audit data to really evaluate what we do. And so every generation of cardiac surgeons or cardiac surgery leaders have a challenge. Our central challenge now, as I see it, is to really manage the specialty through this huge technological change that's going on in cardiovascular medicine, and really making sure that cardiac surgery remains, grows, survives, and thrives in this new environment. And that's really the reason I'm applying for this job, is to really make that central challenge an urgent challenge, and to essentially use all the resources, all the energy, all the time of SCTS to really focus on addressing those challenges.
Yeah. And would you say, we're probably a little bit head in the sand about this, are we?
Oh, absolutely. I think certainly there's no sense of urgency. I think for a specialty who have traditionally been really good at generating good evidence and really good at sort of driving our own fate, I think for the last 5 to 10 years we've really been bystanders as everything around us has changed, and essentially we're feeling the impact of trials that have been done, cardiology, of questions that have been asked in other specialties, and we're sort of just being dragged along. And I think for me it's time for the specialty to really get back into the driving seat and really take control, be in the positions where we're really asking our patients, asking our commissioners, asking government what we want from the specialty and where we want to go, and really kind of what are the things that we need to do to kind of increase volume, increase efficiency, and really make sure that cardiac surgery continues to thrive in the UK.
And how do you see that panning out in Britain? Do you think, obviously numbers going down a bit, but difficulty going up through the roof, so do things need to change, like more minimally invasive, more difficult, dual consultant operating?
Absolutely. I think the answer to that is units need to work really well. Okay, so one of my first jobs, if I am elected president, is to really get to understand every single unit, because units have challenges, and understanding those challenges, understanding the visions of those units, and helping the units to become as best as they can is the way to grow the entire specialty across the country. So I think the answers will be different for different units, but I think you're right. Innovation is really important. Evidence is really important. working together as very good teams is really important as we challenge more difficult operations. So that's where things like dual consultant operating come in, and I'm a big fan of that. I've always, in my role as chair of adult cardiac surgery, that was one of the things that I did introduce, because I could see the complexity growing out and ability to deal with those really effectively decreasing. So I think DCO is a really important part of that. So yeah, I think the answer to your question is getting each unit to be as good as it can, and together, if we can do that, then I think the specialty will be in a really good place.
And I guess 15 years ago we put David Taggart as president, to send him in as a Rottweiler for CABG versus PCI. Do you think you'd be able to get on the other side of the TAVI versus surgery debate, engage with cardiologists?
I think David was an excellent president and a disruptive president. I think that's kind of what we need now. But I think times have changed, and actually the question is slightly different. I don't think it's a TAVI versus surgery question, because I think we know where TAVI is really, really good. We just need to understand where surgery is really, really good, and where surgery offers significant advantages for our patient. And we need to make sure that we're part of the conversation when we're generating the data and writing the guidelines that influence practice. So slightly different approach, but I think no less important. We are in that sort of situation where we really need to kind of meet the challenge head on.
Yeah, in the teaching and training space, do you think we need to start changing the way we train?
Yeah, I think SCTS has done a lot in teaching and training. I think that's one of the things we've always been excellent at. The education portfolio is amazing, and I don't anticipate that we need to change that per se. But of course, we need to teach and train surgeons to be able to meet the actual challenges that they're going to meet when they're consultants. So you're right. So things like the complexity of what they're exposed to is key. Innovation is key, because we're all going to have to be doing slightly different operations than you and I trained on, and so kind of making sure the teaching program reflects that is going to be really, really important.
And I guess we've got quite an international sort of viewership. So just the last thing, do you know what is so great about our national society? I think ours stands out well above its sort of national weight. I mean, it is a great society. Yes.
Yeah, I do think that the key secret is that we all buy into it. I mean, the society is only as good as the members of the society, and I suspect that in the UK our membership rates are really, really quite high relative to other countries. It's been around for a long time, so we've got really good tradition, and actually I think people, one of the reasons why I'm applying for this job is about 3 years ago, I left most of my SCTS roles to be a working cardiac surgeon. And as a working cardiac surgeon, like everyone out there, I can see the value of the society and what it does to improve my working life. So I think just seeing the value of it is important, and I think that's another secret and something that I hope that I can build on if I'm appointed to this job.
Yeah, fantastic. Well, best of luck. I think it'll be awesome, and thank you very much for coming to talk to us here at CTS.
Great.
Thank you so much.
Thank you for having me. Thank you very much.
Cool.